He's assistant professor in the Division of Gerontology and Geriatric Medicine in the School of Medicine here at the University of Washington. Dr. Ong is a clinical educator in geriatrics and at the Harborview Medical Center. He's committed to promoting education in geriatric medicine and gerontology. His interests include patient capacity assessments, sexuality in older adults, which he'll be addressing today, palliative care, and long-term care. Central to his interests are improving medical care for the older population through the advancement in medical education at the undergraduate and graduate levels. So we're really pleased that Dr. Ong could present today. Thuan.
Great. Thank you so much, Michael, for that introduction. Hello, well, my name is Thuan, and I practice out of Harborview. Just so I could give you a little background of my experience, this actually grew out of my clinical experience, actually, here in Seattle at the University of Washington during my fellowship year. And during that time, actually, I took care of numerous patients that you'll probably see throughout this discussion that really stimulated some thought and some questions about sexuality, particularly pertaining to older adults. And that, I think, has grown through the years, and there's have been more questions, unfortunately, than answers that have come to the forefront, at least from my clinical care. And I practice in different clinical environments. I practice in the inpatient side and as well as in the outclinic and the outpatient clinics. And like what Michael was saying is I also practice in the long-term care setting as well, seeing patients in the nursing home and as well in assisted living and also independent living in continuing retirement communities. So you'll see a smattering of that throughout this discussion as well. So some learning objectives. By the end of this lecture, hopefully you should be able to identify the importance of addressing sexuality in the aged population. We'll talk about some common etiologies of sexual dysfunction in older adults. Then lastly, we'll identify some barriers to addressing sexual health in older adults. What we probably and will not talk about is the interventions to treat sexual dysfunction. It's more about a discussion about sexuality as defined in older adults, and we'll go into what that means in a little bit. So we'll start off with one of my first patients that I met as a fellow. So this was a 92-year-old gentleman who was married, and he comes in with his spouse. Just a little background, he's functionally independent. He's independent with his ADLs and IADLs as well. He is Filipino, and he moved here to the States in the 1980s. And prior to that, he was a construction worker. His past medical history is significant for benign prostatic hypertrophy and bilateral hearing loss. And in fact, he actually has very significant spinal cervical stenosis, where there's very limited neck movement that he has in any direction, even to the left or to the right. He can only move his neck about 10 degrees in either direction. And he's also limited in extension and flexion as well. His medications include tamsulosin, which is a medication for treating his BPH, and acetaminophen, and also vitamin D. And so this was my initial encounter with him. And as I was giving him a clean bill of health, saying, you know, you're doing pretty well, and I'm reaching for the door, you know, at my third visit, he says, "Doc, can I get some Viagra?" Which really startled me. And after my third visit with him, it would actually occur to him that he had established some rapport with me where he could actually feel comfortable to asking me for Viagra, which was to treat his erectile dysfunction. And in my mind, I just could not believe at that time and that level of my training and my experience was, wow, with this limitations in his functionality, particularly related to spinal cervical stenosis, that he was still sexually active at this age. And fortunately, also his wife was at this visit, and they were quite playful at this visit, and they discussed it, and we discussed it as a group, that this was a fine idea and fine to try as well. And so the question became, and it has evolved, should we be involved in discussing sexual health in older adults? And it requires us to really reassess our own beliefs and assess our own comfort level with having this discussion. Because in actuality, in geriatrics, if you haven't seen this diagram before, it really revolves and speaks about volume. It speaks about one of the key principles in geriatrics, which is to focus upon function. And within function, there's a psychosocial aspect of the care, and there's a medical aspect of care. And there's also the environment that all encompasses how a person functions in the real world. But you could easily replace that with also sexual function as well with many older adults, is that all these different components, psychosocial, the medical aspects, and also the environment, have a huge impact upon a person's sexual function as well. And I'll jump to the punchline now, and just to say is that it's one of those things that I have matured and incorporated into my own assessments, into many of my initial assessments of patients, is to incorporate sexual function as well and make it normal to ask and be comfortable with it as well. So very similar to that previous overlapping Venn diagram, there's this Venn diagram that I've created that revolves around the whole concept of sexual function. And it is overlaid with the psychosocial aspect of things. The reason why that circle is so much bigger is that at least in my clinical experience and my view of things is that it has the psychosocial aspects and of how a person views their sexuality and their sexual function has a huge and much more significant impact on all the other things that is present. The next thing that usually will occur that we'll talk about is the physiological changes that occur with aging, and also maybe the pathological changes that also will occur with certain conditions that older adults will have as they grow older. And then because of these chronic medical conditions, the medical treatment that we use to alleviate and mitigate some of these chronic conditions can have side effects upon sexual function. And finally, all of these things have an impact upon a person's sexual health and sexual function, leading to possibly dysfunction as well. Okay, so this will be one of the diagrams that we'll be referring to, and we'll work through each one of these overlapping Venn diagrams that are inlaid upon each other. So we'll backtrack a little bit. Is why is sexual health important in geriatrics? Well, it's an increasing number of older adults that are present. Not only that, though, the mere number of older adults, but these older adults have higher levels of functioning compared to their other cohorts that have lived before them. And it's consistently, at least in my clinical experience as well as the research shows, that many older adults view this as a vital part of their relationship and also a vital part of who they are as well. Just because you grow older does not mean that you lose your sexuality. And older adults as well participate in risky behavior as well too. And so it's just not younger adults that participate in risky behavior, but older adults as well. And why is that important? Well, that's related to sexually transmitted diseases. And compared to younger adults within their 20s, people in the ages of 50 and 75-year-olds are 1/6 as likely to use as condoms when you're comparing it to younger cohorts. And particularly in 2000, in the UK at least, 11% of newly diagnosed AIDS cases were in people over the age of 50. And so it's related to this perception that older adults have less risk of contracting sexually transmitted diseases, and hence maybe using less safe sex practices as well. And so that figure, or that number that I had given you in the UK, concurrently that is also seen within the US as well, is that for older adults over the age of 50, 10% of AIDS cases are accounted for in people over the age of 50. But that doesn't mean that there's a huge amount of risk, because I want to make sure that this discussion is honest, is that still the risk of contracting new diagnoses and new HIV and AIDS cases are still in the younger population. So what you have here is a break off in age and over the amount of years. So in the dark blue here that you have outlined are the people over the age of 50. And as a person, and the dark red here is 40 to 49 and 25 to 39 and also 15 to 24. And then you have on the left side is the heterosexual women, and on the right side, heterosexual men. And so, to be honest, that there is still a risk to older adults, but it's still where that, although the risk is present, that the major risk out there is still for younger adults, just because of maybe the risk and the number of times that they do have sex, which we'll get to talk to in a little bit. And this, by the way, is data from the UK. So it's for sure that sex is maintained within older adults, and many studies support that as well. In fact, nearly 80% of women are still sexually active. But what this slide illustrates, as well as into the next table that will fill in the box here, is that although they are sexually active, there's a very small number of individuals that use condoms and practice safe sex methods. And this study that is alluded to here was in Atlanta, Georgia. And so this was a survey of community dwellers, particularly women over the age of 50. And what you see, at least in this study in Atlanta, Georgia, in women over the age of 50, in this particular study, that the median age was about 60 to 58, just depending on which category. But for people who practice safer sex, believe it or not, that the women actually depended on their partner for the condoms, versus a very small minority of patients subjects in the study obtained condoms themselves. So, and then there's another cohort of subjects within the study that they trust their partner for it, where they do not practice safer sex methods within this cohort, where they just outright depend upon their partners for it. And so it's a huge discrepancy, and to underestimate the risk of contracting sexually transmitted diseases in older adults. And what we'll talk about later as well is that there might be a cohort effect that we'll discuss. And likewise, in women, men are also sexually active. In fact, the literature bears out that men are usually more sexually active even in their later years as well, where over the ages of 60, nearly 94% of males are still sexually active, even though if they might not be married as well. We'll jump to my next case. This is Irene, and this is another woman that I saw during my second year of fellowship. She's a 69-year-old community-dwelling Kenyan woman who has lived in the United States for the past 10 years with her family, but she recently traveled back to Kenya to visit her other part of her family. And she was actually brought back into clinic by her daughter for this strange movement disorder, that she developed this shuffling gait for some reason, and this has just been present for the past 2 months since returning from Kenya from visiting. Her past medical history, her family history, and also medication, she had none actually. She was very actually well functioning. She was married, and her husband is actually paraplegic from trauma. They've never had sex, at least that's what I've been told, for the past 20 years, because he was paraplegic and he didn't have any interest in sex. Her husband still lived back in Kenya at this point. And the exam, she was mildly on the hypertensive side. She definitely had this shuffling gait. She has masked faces. She had no cogwheeling or tremor, because we were concerned maybe these are early signs and symptoms of Parkinson's disease, potentially. Some abnormalities that when we were trying to see what was causing this was that what we found was that she had a low platelet count, and she had some anemia as well, but with a normal MCV. Her head imaging, her non-contrast head CT, was unremarkable. It didn't show any evidence of strokes or any mass effect. And we'll return back to Irene in a little bit. But before we move on to that is just readdressing this risky behavior, particularly in older adults. Although that there is some risk to older adults, what we find within primary prevention in clinical trials trying to prevent these risky behaviors, actually older adults are excluded, believe it or not. And so what I'll talk, or what we'll focus in on, is this thing that is highlighted in yellow, where they looked at primary prevention and looking at particularly risky behavior related to irresponsible sexual behavior, basically unsafe sexual practices. And if you look at the mean age, that it is 23 right there. And so it's very, very limited, and it's very much more focused upon the younger cohorts rather than the older cohorts. So we might be missing out on some primary prevention as well for education. So coming right back to Irene, it turns out that she had HIV, and this was confirmed. And she had a neurocognitive dysfunction from her HIV. And once she was treated, believe it or not, her symptoms actually improved. They didn't revert back to normal, but as soon as she was treated, it improved somewhat. And so it's postulated that it was related to this HIV infection, which she had no clue about. And so when I was seeing her as a second-year fellow, it made me question what my practice is that as a geriatrician, I love it when family members are present within the room and provide some history that I can confirm. But there were some significant barriers, particularly with Irene when I interviewed her, because there was a huge language component of it where there was an interpreter present, and oftentimes the interpreter was male. There was a culture per se, because I did not ask particularly what her sexual history was and if she was still sexually active. It was actually presumed, really, and I just asked, does she still have sex with her husband when she went home? I didn't ask about other partners. And the other thing is that the daughter was in the room at that visit as well, and so there were some potentially preconceived notions and maybe not wanting to answer some questions truthfully as well. And of course, maybe some ageism as well when I was much a young doc, not seeing that maybe that this woman could be still sexually active. We'll backtrack a little bit and discuss what sexuality is. And I'm not going to read this entire slide set. It's very complicated, and that's what is the take-home message, is that sexuality, believe it or not, is very complicated. And what I have here highlighted in red talks about the external cues, about the stimulus that we have, and it talks about heterosexual or homosexual orientation. It talks about hormones as well as gonadotropin-releasing hormone playing into sexuality, a personal experience, the psychosocial aspects, and the expression of one's sexuality, and then the paired bondness that a person develops through a person's lifetime that has an impact upon sexuality. And this comes from the concise dictionary as well, and by no means is it concise. There's numerous definitions out there, but all of the definitions are very encompassing and incorporates not only the personal experience, but also the expression and also the medical aspects of how a person is determined to have sexuality, which is a little bit of difference from sexual health, which is the integration of all of those things, the somatic and the emotional and the intellectual and the social aspects of sexual well-being. And what we'll talk about, or very little, is the sexual dysfunction here is as well. When we talk about sexual dysfunction, we focus upon the inability to react emotionally or physically to the sexual stimulus in a way that's expected of the average individual, or better yet, to one's own standard, which I think is a better definition to rather than the average individual. And part of that is because as a person grows older, that we're dealing with a very heterogeneous population, and it's very difficult to say who the average individual is. So rather gauging it to one's own standard, I think, is a better way to describe it. And then in the American Psychiatry Association, the DSM-5 criteria, they break it down to different sexual dysfunctions in terms of female and male. They break it down to sexual desire and sexual arousal or orgasmic or sexual pain. So these are all phases and parts of the act of having sex that a person can have dysfunction in. Right now, we're going to transition to talking about the sexual health and the sexual function as well. And what we're going to touch upon this is the psychosocial model, that all these different things come together and has this psychosocial impact. So there's and intrapersonal factors that a person has life experiences that will probably shade and dictate what a person's sexuality is, a person's culture, and also a person's religion. And it's all these things that encompasses the sexuality. One of the studies that I want to allude to that really illustrates that sexuality is a global issue, as well as the global study of sexual attitudes and behavior. And this was a study that had over 27,000 subjects, over 29 different countries, and they interviewed 40 to 80-year-olds, and they had an oversampling of people who were of the older age cohort. They asked these individuals really 4 aspects of their sexual well-being. They questioned them on the physical and emotional satisfaction of their sexual relationships by asking them these 2 questions. During the past 12 months, how physically pleasurable did you find your relationship with your partner to be? And then also the emotional side of things is, during the past 12 months, how emotionally satisfying did you find your relationship with your partner to be? And so this incorporated the relational aspects of the measurement. And then they asked about their sexual health and function. If you were to spend the rest of your life with your sexual function or sexual health the way that it is today, how would you feel about this? And then they would rate them. And lastly, they rated people on the importance of sex in one's life. And what the authors found was quite amazing, was that they found that the results were clustered in 3 different regions. So what you see here are cluster number 1, 2, and 3. And so cluster 1 is in this dark blue versus cluster number 2, which is in this lighter blue, and then cluster 3 is in this turquoise. What all these things represent is that subjective sexual being was found to largely consistent across the world regions, and they were able to segregate and separate, distinguish them from these different clusters. How the authors deem it was that cluster number 1 was where that these countries had more of an equal footing between men and women in terms of a gender equal regime, but that's debatable, of course, versus cluster 2 and 3, though, that was where that these were more male-dominant countries where that they segregated or separated these individuals in. But what they all found that were some general findings was that all 4 aspects of subjective sexual well-being, men consistently had higher means than women in all these 3 different clusters. And that self-perceived health status positively affected all measures of sexual well-being. So the healthier a person perceived themselves, the more positively they saw that their sexual well-being. And interestingly enough as well, that non-marital relationships were associated with higher levels of subjective sexual well-being than marriages, particularly in men. Stated another way, non-married people had higher levels of self-perceived sexual well-being, and that was across all 3 of these different clusters. And the duration of the relationship that you were in were more positively affected as well, with emotional satisfaction of sexual function. So it's very much consistent throughout these countries and the world. We'll move a little bit from the global aspect and talk about the culture and how we perceived individuals within the United States. Oftentimes, a sexually active individual is not readily accepted as part of the parental role. And I think that this could even be where I could give the anecdote. I have a 9-year-old daughter, and whenever she sees me hugging my wife or kissing my wife, she goes, "Ew, I just can't stand that." And so I think that this is part of what that reflects, is that having the expression of love and a sexually active individual, it's just not part of the parental role that many of our older adults have had and continue to have that role. And particularly within our culture as well, older people are depicted in films as having no sexual life at all. And where it's replaced with a tenderness and warmth, and it's basically touching. And unfortunately, because of our audiovisual limitations, I had a video of Cocoon ready to go, and this link, unfortunately, this hyperlink doesn't work without the audio. But I will give you just a preview of it, of these films. What these three films here outline is really the progression of how we view older adults and sex as well, and the sexuality as well. In Cocoon, film was in 1985, but this was a film where it depicted these older adults living in a retirement community, and that this alien being came down and gave them extra strength, and then they developed this new energy to have sex. But it's interesting because one of the critics of this movie wrote this really great summary of it. It's built-in frailty that is magnified as the story progresses. Its conception of old age, though wonderfully sympathetic, unfortunately, it's filtered through and limited by the eyes of the young. So it's perceived through the eyes of the young. And you progress through to 2003 in Something's Gotta Give, where Jack Nicholson and Diane Keane, playing the roles of older adults, are very much, if you remember the movie, that these individuals are very attractive and they're very sexually active as well. And it progresses into 2013, where it really, into the movie The Best Exotic Marigold Hotel, where it has couples and they have these relationships that are very rich, warm, and tender, and also that there is sex involved as well. So hopefully that it paints a picture that maybe our culture is changing for the more positive, that these issues are coming to the forefront. And incidentally, if you saw that there was an article in the New York Times just yesterday, actually, in the health section, that talked about a gentleman who was being persecuted for having sex with his wife, who was living in a skilled nursing facility, who had dementia. And so it's a very interesting article, but I think that now, carrying on this thought that this is becoming more talked about within our culture and becoming more open as well. And as I alluded to before, that there are generational cohorts as well, because we have seen some dramatic changes in attitudes and culture since World War II. For example, there's a higher rate of divorce and re-establishing new relationships with other people as well. And I think that is one of the things that I've noticed, at least within my clinical care, is that the individuals that I care for who are 90 are very different from the individuals that I care for in my late 70s, just because of these generational cohort effects. And I think that as future age cohorts that progress through and get older, that they will be more sexually active, and that it's going to be basically an extension of their middle life of what that is. And so if you were sexually active at that point, that they will maintain sexual activity as well. And because there's a longer lifespan that is spent with higher level of function, as I alluded to in my introduction. And also that there will be a higher level of expectation as well in these younger cohorts that are aging in to see a geriatrician now. And yet there's also and intrapersonal aspects that are related to sexuality and aging as well. As a person ages, then there's different things that come to life, particularly mood disorders, much more prevalent, and as we get older, and just the loss of our friends and also our spouse in suffering through bereavement and grief. And one of the things that I alluded to is lack of privacy as well. And so some older adults living with their family members or sons or daughters or other relatives, or maybe in a continuing retirement community, there's a huge issue of lack of privacy. And one of the largest barriers is really a lack of a partner, And unfortunately, women are less likely than men to be in a relationship by the sheer number of odds. Unfortunately, and unfortunately, because of that, that at the ages of 65 to 74 years old, there's 83 men for every 100 women. And that number only gets worse as a person gets older, as men unfortunately die off and women continue living. We're going to switch to some qualitative data that was done within the UK. And so this study interviewed women who were 70 to 79 years old, and they interviewed these women who were married at least twice and whose second or third marriages occurred after the age of 50. And what this researcher found, that they found three themes that pervaded the qualitative data when they interviewed these women: that there was a later life sexual chemistry that was improved compared to their prior, and there were health issues that impacted their sexual health and function, and that affection and companionship were perhaps more important than actually having sex. So we'll talk about each one of those themes first. And so the first one was the sexual chemistry, that women found that the relationships overall, that later in life, that it was more satisfying, that there was freedom from childcare, and there was a changing of the social norms and better communication between their second and their third relationships. And because of this age and wisdom and experience, that there was also an increase in confidence and self-knowledge. But where the dissatisfaction came from, it came from the partner's health problems, actually. And early on was emotional incompatibility. And so this is one of the excerpts that was taken from the original, or from the study. And it's from a married 52-year-old woman who remarried at the age of 51. I may have had fantasies, but I just couldn't bring myself to say anything to my first husband. Can we do this? Can we do that? And the years go by, and then you stop even thinking about that. Sexual contact becomes a routine that you have to have. But like I say, you're going through having children, you're tired, you're working all the time, and you start getting into the sort of perimenopausal stage, and you're even more hormonal than a teenager sometimes. Now I've passed that, and I think a lot of that is a state of mind too, So it's a much calmer state of mind, and my husband is very open, and we can talk about things and make me feel at ease and not uncomfortable, and it's just much nicer that way. I'm having a lot more fun, and so it alludes to that more satisfying part of the relationship that we had discussed. This comes from a married woman at the age of 71. She remarried at the age of 60. My former husband was also, how can you say, green behind the ears. Really, it was the first time for both of us, and because I basically already didn't love him, it was difficult, I found. That illustrating the dissatisfaction from the emotional incompatibility. And lastly, this comes from a widowed 90-year-old woman, but she remarried at the age of 62, but unfortunately she's widowed already. I learned to do without sex because of his type of chronic illness. Become impotent and they lose bladder control, and I mean they're finished. I guess I was so tired most of the time looking after a husband who was helpless. And that really talks and illustrates the dissatisfaction that comes from the partner's health problems as well. And last, the other theme that the researchers found was that there was a huge impact on later life sexuality. And much of it is medication induced, which will be a recurring theme that we'll talk about as well. So this comes from a married 76-year-old woman who remarried at the age of 72. So four years into her second or third marriage. We try to have sex, but with my legs, my hips haven't been all that great, so I haven't been able to do it. And he can't really perform either, so it's no loss at this age. I don't miss it at all. So health having an impact on sexual function. This comes from a married 69-year-old, and she remarried at the age of 66. He has asthma badly, and I don't think it's the asthma medication that does it to him, but he is on blood pressure stuff too. And the doctor said to me, I hate to tell you this, but that's the end of our sex. Because and my husband is very unhappy that this is doing it to him. Maybe if they took him away, if they took him away from some of this medication that he's taking for his blood pressure, things might smarten up a little bit. Really talking about the medication induced, and it really calls into question, at least my own practice, is that I frequently prescribe antihypertensives to my patients, but rarely do I talk about the sexual dysfunction about this. And what we'll talk about too are CNS active medications such as antidepressants as well have a strong factor in it. And then the last theme that the researchers found was that these women redefined sexuality in later life. They talked about how the importance of sex, the act of having sex, declined, that it was replaced with more about the intimacy and the companionship that was more important. And in fact, that sex was actually icing on the cake, that usually the fondling and the cuddling led to sex when they were younger, but actually if it ever became that, it was merely icing on the cake. And so women really redefined their sexual needs and desires to meet the available resources that they had at that time. And so this is from a married 71-year-old woman who remarried at the age of 60. When you get older, well, it takes longer to get aroused and that sort of thing, and your interest goes down. But we both feel it doesn't. It's not our most important part of our life. What is important is that we cuddle up and that we feel good sitting together or lying in bed together and all that sort of thing. And then if there is sex on top, it's that extra good. So really talking about that sex is that icing on the cake and focusing on the companionship that is more important. This is from a married 76-year-old woman who remarried at the age of 72. He's very attractive, or he's very attentive and very loving. He comes over every once in a while and gives me a great big kiss, and he's very warm. So what else do I need? And as I say, the companionship is the most important thing at this age. And so when we refocus back within the U.S., one of the more important studies within the U.S. Comes from the National Social Life, Health, and Aging Project, also known as NSHAP. And what this study looked at was that they surveyed community-dwelling older adults from the ages of 57 to 85-year-olds. They had an oversampling of people over the ages of 70 and above. They had an oversampling of minorities, African Americans and Hispanics as well, and they performed in-home interviews. And they assessed people for sexual health and sexual well-being. And what this chart illustrates, what panel A illustrates, what I'll walk you through, is that they break it down to these different age categories on the x-axis here. And they talk about, and on the y-axis is where respondents who were sexually active in their previous year. And so these are all respondents who were sexually active. And that what on your screen, it should display red, the difference between red and blue. Blue indicates male, and red indicates females. And then these different symbols here, the plus sign represents where a person reports that their health is excellent or very good, and also that the triangle indicates that they are in good health or fair or poor health. And what panel A shows consistently as males, as represented in blue, are more sexually active compared to females in all age categories. But more importantly, as a person gets older and ages, that the sexual activity decreases as a person gets older. Whether or not this is normal age related or it's just one of those things that we observe, it's an observational study that we can just make a note that yes, it is one of those things that we observe as a person gets older, sexual activity does diminish. And one of the things, and the other thing here, is that people who rate themselves as having excellent or very good health tend to have more sexual activity compared to people who have fair or poor health as well. And this is consistent for men and women. And panel C essentially shows that as well But what the authors did here is change the y-axis, where they looked at respondents who were sexually active in the previous year among respondents with a spouse or in another intimate relationship. So you had to have an intimate relationship to have sex, because there was sexual activity among those not in a relationship, which I think is incredibly important from a clinical aspect, at least for myself, because even if I'm interviewing or I'm making an assessment in individuals who aren't in a relationship and they're older, oftentimes I forgo, or when in my youth, I didn't ask about sexual activity. So it's important to note that there was still sexual activity among those not in a relationship. And in fact, that it was very high in men, so nearly a quarter of men, or over a fifth of men were still sexually active that were not in a relationship, and 4% of women were sexually active. And lastly, 35% of women rate sex as not being as important, where only a small minority of men really rated it as not at all important. And when we look at observational studies within the UK as well, this is very much consistent as well. So this was a study that was recently completed called ELSA, the English Longitudinal Study of Aging. Very, very similar. They surveyed community-dwelling older adults between the ages of 50 and 90. They took a cross-sectional data, looking at the data that they collected in 2012 to 2013. They had interviews and self-completed questionnaires. Very, very similar findings to the previous study that we had talked about, where self-rated health correlated with sexual activity, and the prevalence of sexual dysfunction increases with age, and also that also sexual activity decreases with age as well. And females were less sexually active at all ages, and found that it was less important part of their life compared to men. So in summary, when we talk about the psychosocial aspects of aging and sexuality, sexual activity and satisfaction are highly associated with self-assessment of health. The psychosocial factors definitely modify the impact of age-related changes on sexuality and also the expression of. And some very common reasons of sexual inactivity include the lack of a partner, the partner's health status, and also one's own health status as well. What we'll talk about a little bit here is the pathologic changes and also the physiological changes that occur. And so what we talked about is frequency of sexual activity definitely declines with age, and that numerous small studies link this with the decline of emerging chronic conditions. And I think that bears out from the observational studies that we talked about. But there's also a decline in the libido, or the sexual desire, that is also with age. That possibly is related with the sexual hormones that also decline with age. And sexual satisfaction does not change in those that are sexually active. And so, stated a different way, those people who are sexually active in their middle age and continue to be sexually active within their late stages of their life, that continues to not change as well. They continue to be sexually active, and they continue to be sexually satisfied as well. So what is really age-related and what is abnormal? Like I said, it's very difficult to tell because it's such a heterogeneous population that we're talking about. So we can only talk about cross-sectional data and observational data. But many older adults, 50%, report having at least some sort of bothersome sexual problem. A third of these individuals having at least two of these problems. And by far, the ones that are most prevalent in men has to do with achieving and maintaining erection, where that the prevalence rate is nearly 40%, and those afflicted, that they are extremely bothered by this problem, close to 90%. And this comes from the National Sexual Health Study that we had talked about. And within females, it's usually a lack of interest that is the most prevalent problem within women. And for those who are bothered by it, who have this problem, that 60% of people are bothered by it as well. And on this table, it also lists the other types of sexual dysfunction that was found within this observational study. There are age-related changes, and I'm not going to talk and go through all of this just in the interest of time, but this is all the things that can happen, that does happen as a person gets older in terms for males and also females as well. One of the major things that does happen is that there is a decrease in the sex hormones as a person gets older, and so testosterone and estrogen that we talked about. But there's also some effect on serotonin as well, and whether or not this is related to dopamine, it's not certain yet, but it's definitely seen when we start individuals on the typical SSRI, and so one of the side effects of SSRIs is sexual dysfunction, and so this serotonin system definitely has a role within sexual physiology. And lastly, the dopamine system has an impact upon sexual function as well, and this is also seen in people who are started on antipsychotics, for example, and that there is dysfunction within that. And lastly, the other neuroendocrine system that could be affected is prolactin. We talked about the neuroendocrine system a little bit, and now we're going to talk about the nervous system. And it's suffice to say that it's a very complex system, that there's a psychogenic mechanism, but there's also a reflex mechanism too. The psychogenic mechanism, and this graph is pretty busy, but I like this graph much, much better. So this psychogenic talks about the stimulus that goes into the brain, where the visual, the tactile, the olfactory, the imagination, for example, that goes into the brain, that stimulates some sort of activity and then relays that to the spinal cord, where there's a reflex mechanism within the pelvic nerves, where then it stimulates the penile structures to have a erection. And if there's any dysfunction, or if there's any break within the system, that there can be dysfunction within that as well. The next system that we talk about is the vascular system, which is important because so much of it is composed of blood flow as well. Particularly in men, the erectile tissue consists of the corporal cavernosa corpus. It's a big cavity that is filled with venous blood, and it's under the beta adrenergic control. And so sometimes when we start individuals on a beta blocker, that can also be one of the things that causes sexual dysfunction because of that as well. And so the vascular system is important for numerous different reasons, not only for blood flow and for maintaining a erection too, but there's also some evidence that it could be also a sign of early peripheral vascular disease. Believe it or not, you can actually get a penile brachial index, meaning that you could feel for blood pressure, or you could feel for blood pressure there. And people who had a penile brachial index that was decreased had a significant risk of having a myocardial infarction compared to patients who had a normal or a high brachial penile index, indicating that there is some vascular disease present there as well. Okay. The last thing the other system that is associated with sexual physiology is the musculoskeletal system. Very similar to what one of the women's within the qualitative study said is osteoarthritis, and the flexibility to get into positions for sex becomes incredibly difficult as a person gets older. And so osteoarthritis being one of the significant barriers within sexual health and sexual function. So just a summary of the age-related changes. Sexual activity and desire declines with age. And there's multiple different systems that have age-related changes that contribute to sexual functional decline, unfortunately. And sexual dysfunction is very common, but there are things that we can do about it. And talking about things that we can do about it, and this was simulated by one of my patients recently who had a hip replacement. This looked at sexual behavior in patients, and particularly in males, who had elective hip or knee replacement. And they followed these patients before they had their surgery and 6 months after. And they asked about their sexual activity, perioperatively and post-operatively. And so what you have in here are people who were sexually active post-operatively, which is the top here. And then this is pre-op, so meaning before their surgery, they were sexually active. And so the mere fact that they had a hip replacement or a knee replacement, that there was a percentage of individuals, nearly a quarter of individuals who were sexually active before, had then lost sexual activity or no longer was having sex at 6 months out from their surgery even. And so it's an important thing that I don't think surgeons talk about very often, is that could be a downside of having these operations to treat osteoarthritis as well. And when they looked at people who looked at their mean ages that fell into these categories, it turned out that age was one of those variables that was significantly correlated. So as a person was much older in this category who were sexually active before versus after their surgery. There are many risk factors other than osteoarthritis and also having hip or knee surgery replacement. This is a list of all of those common medical risk factors that can have a play in sexual dysfunction. What I'll talk about much more is the medication aspects, because as I trained in geriatric medicine and also as an internist, I prescribed many of these medicines that fall into this category as well. And so this is a list of all the common classes of medications that causes sexual dysfunction. And I will have to say that the literature supports that the most common iatrogenic cause of sexual dysfunction is really medication-induced, is that we put patients on medicines that cause sexual dysfunction and without realizing it, without having this discussion and asking them if they are sexually active and if this has an impact upon their function and their quality of life. And some research has shown that compliance with antihypertensive therapy can significantly be improved by minimizing drug-induced sexual dysfunction. And how you could do that is having that discussion or switching it to a different agent potentially as well. As you can see is that there are some medications that have a higher impact on sexual dysfunction than others. For example, hydrochlorothiazide, a very, very common medicine, can induce sexual dysfunction and particularly erectile dysfunction in 32% of people, in particularly males. And the other category of medications that is often prescribed are antidepressants. And the take-home message with the antidepressants and what we could do about it is that they're dose dependent usually. And you could consider having a drug holiday or a dose reduction as well. We'll go through some cases towards the end of here that will talk about how if you have clear lines of communication, we can actually move some of these medications around during the day to help individuals. Some of the barriers to assessing sexual health is really the poor data that is out there. Is that there are data out there that we've alluded to, that we've included within this talk, but all that data is all cross-sectional studies really, and it comes from relatively young cohorts as well. If you look at these studies and the age ranges that include. And so it's really poor data coming from really relatively younger cohorts. And lastly, it's a lack of physician awareness, because who's doing the prescribing of these medicines other than physicians? And so it's my colleagues, unfortunately, that are doing this. Studies have also consistently shown that healthcare providers report great discomfort and really a lack of knowledge in discussing sexual health in older adults. And sexual health, believe it or not, it's not discussed in 60% of women. These women, this figure that I'm referring to, were actually going to a gynecologist. And so it wasn't even discussed there. And so this is subspecialty care even. And so it wasn't even discussed. And this study that I'm going to be talking about supports where we just talked. They surveyed primary care practice, and they surveyed patients within a primary care practice. The mean age was 81 plus minus 6 years of age. 7% of women reported physician inquired about their sexual health in the past year. 7%, that small. And then 32% of men. And 4% of women reported initiating the discussion in the past year themselves. And 36% of men. But that number actually significantly increases when they felt that really the doctor should be talking about this and be asking me about this, really. And so nearly a third of women felt that the physician should be initiating this discussion, where oftentimes they're not. And 86% of male felt that they should. And so really it's the lack of physician awareness that this is even a problem. We're going to jump back across the pond and look at some qualitative data where this individual and this researcher looked at general practitioner attitudes in older adults. 3 big themes emerged that really we've discussed somewhat about already. That sexual health is not proactively discussed with older adults, particularly older adult patients. And sex is deemed as, quote unquote, not a legitimate topic for discussion in this age group when they surveyed these practitioners in the UK. And these general practitioners talked about the lack of training that they had in their education. And the many GPs had preconceived ideas about sexuality in older adults. And so this came from a male physician who was age 40 to 49. The last time that anybody of that sort of age group did discuss a sexual health issue with me, and I did have 1 or 2 people talking about vaginal infections, but the only one I can remember, it must be 10 years ago now. A chap came in and his wife had died of motor neuron disease, and he was in his 70s. And he sat down and said, "What I miss is the sex." And it rather took me aback because he was so upfront about it, and I wouldn't have expected that from that generation. From him, that was a major issue. Just reflecting the idea that we're not really have our radar and our antenna up to talk about this issue. This comes from a female physician, also age 40 to 49. Around diabetes and blood pressure, say a man in his 40s, I might warn him and say, this can have an effect on your sex drive, speaking about the medicine. Some men find it causes some problems. I might not mention it to a man in his 70s, so maybe that's a barrier that I'm putting up, whereas I would assume a man in his 40s would be married and sexually active. But I might not assume a man of 70 was, and I wouldn't know whether to bring it up, really reflecting what we had really talked about as well. And so it really has to do with the physician's own preconceived notions. And it really, as well, and I could talk about my own personal experience that it's a lack of undergraduate and graduate medical education. This comes from the same study. This is a female physician in the UK, age 50 to 59. In some ways, you talk to younger people because you're trained to do that, and you do what you're trained to do. Nobody has ever trained me to talk to older people, particularly related to sexual health. And it's also societal perceptions which we already alluded to in terms of our culture. So what can we really do about this? What I would advocate for is that we need to normalize this, make sexual health assessments very much routine. And that's one of the things that I've incorporated into my new patient visits as well, is making this a sexual health assessments very much routine, and asking about it, and asking about, does this impact your quality of life, because it has a huge impact on quality of life, and like we were talking about before, it's vital to a relationship. And when you're thinking about and trying to figure out whether or not a person, if they do have sexual dysfunction, it can be classified in these 4 broad categories. Thinking, is this something lifelong? Very similar to, is this something that you've always had problems with, or is it acquired, meaning it's because I just started a new medicine and this is something new? And is it situational, or is it generalized to something that is more perverse? The other thing that I would advocate for is, in the process of trying to normalize it, is to ask if there are any sexual concerns or complaints, and ask about what normal sexual patterns and interests are before. Remember, gauging it to what's one's own individual practice is, and how their sexual function was before. What has happened now, and how that impacted sexual health as well, asking about that. And also reviewing the possible illnesses and the medications, and also the age-related changes that we talked about. All incorporates into the sexual health assessment. There's other sexual health assessments that you'll find within the literature, such as PLICIT, which is a acronym. I personally don't find that as clinically useful. This is a couple that I actually am the physician for, both the husband and wife. And this is John and Sally, and she is 72, he is 77. They've been married for 44 years, and they have a very loving relationship. Sally has a slew of medical conditions that is listed there, and John has his own as well. And John asked for refills for his erectile dysfunction medication. They openly discuss changing their routine with me, and it's one of the more rewarding clinical experiences that I've actually had, being involved in that relationship with them, and being closely entwined and helping them both achieve quality of life. And so one of the things that we talked about with treating his hypertension with, he actually moved his hypertensive meds later into the evening. And so rather than having sex in the nighttime, which they commonly did, they had sex in the morning time before he took his medicines. And that they've tried other things such as oral sex, and they're very open into having that discussion. And I think that what this case vignette illustrates is to communicate. And I think that it's very hard as a clinician to emphasize this, because oftentimes you're only caring for the individual rather than the partner. But in geriatric medicine, I often find myself caring for both at times. So it's really important to educate our patients, to communicate with their partner, talk about your abilities, the needs, desires, and also your concerns, and talk about their routine and how to change up the routine and troubleshooting that routine. This is a case of vignette of one of my dear and fond patients, David C. He's an 85-year-old male who is living in a retirement community. He's widowed for 6 years now. He has an extremely strong social network in the continued retirement community that he lives in. He lives in a assisted living facility. And when his wife died 6 years ago, he had a neighbor, and he had many people who came to visit with him. His neighbor visited him very often, checked up on him, and that relationship developed and blossomed, where that they are romantically involved with each other. And there's no sexual activity, but he definitely shares with me that he holds, he hugs, he kisses, and that he very much endears the companionship. It's very interesting because David is getting more frail, where he has to maybe potentially move out of his assisted living because of cost and the increase in care that he needs. And right now his family and I are grappling with, well, how do we break up, or do we even break up this network that he has? And we're trying to involve his significant other now, his new significant other's family. Say, is there a way that they can move in together potentially? And so it requires a lot of troubleshooting and working on how we can improve the quality of life for the people that we care for. And so I just want to emphasize, and I think that what that David's case talks about and would to emphasize, my screen just went blank.
Mine too.
Yeah, is to redefine.
I don't think we've gone out. John?
Yeah. Well, my screen just went blank. Is to emphasize redefining. I'm gonna hit cancel. Is redefining what sex means really, and expanding that definition as well. Is that holding, touching, and massages can be very, very important because as human beings, touch is incredibly important as well. So in conclusion, sexual health is an important component of successful aging. There's a great heterogeneity of later life sexual health needs that is reflected in our older adults. And I'm going to quote this is, most of our aged stop having sex for reasons similar to those why they stop riding a bicycle: general infirmity, fear that it would expose them to ridicule, and for most, lack of a bicycle. So it's very, very important to kind of just remember that quote as the reasons why we should also inquire and make it normal to ask these questions. And for sexual health, medical and iatrogenic causes of sexual dysfunction is very common, and very much so that there's psychological and relationship influences that are key determinants as well. Okay. And so these are some additional resources for the people who are online that you can look to for more sexual health and function. I'll be happy to take some questions.
Okay, thank you very much, Dr. Ong. We actually have one question already from the Anchorage AHEC, and that asks, what about people with dementia who still have sexual impulse and needs? Any advice to caregivers who are not partners?
Yeah. That becomes extremely difficult, and it depends on the care setting, and it depends on what the goals of care are for that individual. Meaning if a person has disinhibition and their sexual expression comes out and they have disinhibition because of their dementia, for example, and that is not accepted within their current living environment, that there are ways that staff and facility and even family care members can redirect what that behavior is. And lastly, and it's a last resort though, that there are medications that can be prescribed to disinhibit that, but that can be a very tricky situation depending on the living environment. And so I think it really pertains, and it's important to identify what that environment is. So if you remember back to the overlapping Venn diagram, the environment is also on there. It's critical to assess.
Yeah, I mean, one of our other sites points out along those lines, sexuality in nursing homes can be a sticky issue. Often rooms are not private.
Correct. Often rooms are not private, and there's also caregivers that are present there that have their own beliefs as well. Right.
While we're waiting for other questions to come in, I was actually struck by the fact that hydrochlorothiazide, which doesn't have any CNS actions, is linked to as much erectile dysfunction as it is. Do we know anything about mechanisms, dose response?
No. It's not every individual will have it. I think that's the key, is not every individual will have erectile dysfunction from hydrochlorothiazide. But asking whether or not it's been a problem, I think, is the follow-up question is when we start these medicines. But the mechanism of action is not known, though.
Has it been recognized as a side effect in labeling?
I think that I don't know that for certain, but I definitely know that it's one of the things that as a provider in geriatric medicine, I am aware of, yes. And whether or not, if it's a black label, I'm pretty sure it's not a black label, but whether or not it's one of the listed side effects, I would be very surprised if it wasn't in the insert of the medicine.
Mm-hmm.
Yes, a question here.
Prolactin relationship, does one antipsychotic, is it different from another? Aripiprazole is usually labeled as having less effect on prolactin in relation to younger people.
Yeah, I think that is a very interesting question, and I don't know if they've looked specifically at sexual health and sexual function. In theory, though, yes, I think that in practice and theory, yes, that is true, that aripiprazole has less because of that, because it has less an impact on the effects of prolactin when it works. So.
Okay, just mentioning to our remote sites, if you have questions, please type them into the chat box.
A couple are still typing.
Okay. In fact, one just, Kenny Lake in Alaska just came in. How prevalent, let's see, how prevalent is lower back issues in dysfunction?
Lower back issues such as back pain? Would
Yeah,
say?
that's what I would infer here.
Yeah, you know, there's not specific prevalence data on back pain in particular. There's prevalence data on osteoarthritis per se and degenerative joint disease. And so I don't know if that answers your question, but there's not specifically prevalence on lower back pain that I am aware of.
They clarified that that was indeed the question, was
Yeah.
lower back pain per se.
Yeah.
Just a compliment you received from Anchorage saying, nice job on a sensitive topic.
Yeah. Yes.
And we have another question. My question, how does sexuality in later age and dementia relates to other groups outside of the United States, meaning like Brazil, Central America, India, etc.? In other words, are we being, Americentric or industrial-centric?
Yeah, you know, I think that's really interesting question, and I don't know if there's any data to support what I'm going to say at all. But I think it has a lot to do with living environment and also family perception when you're talking about people with impairments in ADLs and that they need to live in a supported environment. And so, yes, most of what we've talked about is Westernized and Western focused primarily, and that's where the data comes from. I think that you can only, what I can only do is extrapolate, is that when you look at the global health studies that we talked about, that there were things that were very much consistent, and that looked at people who did not have cognitive impairment. And so this whole issue with dementia and cognitive impairment and sexuality, I think that's a whole new ball of wax that needs further research. And so there needs to be a separate slide about other issues and other research opportunities, but that would be a huge one. And I think the New York Times article that I had spoken about really talks about the need for research, particularly that this is a growing population as well now.
Mm-hmm. And we have another question. Can you give some practicals about how or what you incorporate into your geriatric evaluation with regards to sexual health?
Yeah. I think that in my initial assessment, that I make it very much routine, very similar when I ask about tobacco, alcohol, or any illicit drugs. I ask them, are you still sexually active, and are you happy with your sexual activity and your sexual function at this point in time? Who do you have sex with? And I make that very much part of my routine. And I would have to say that, at least in my clinical training in medical school and through residency, that wasn't emphasized. That wasn't emphasized at all, was that we did this, that we made these sexual health assessments in people who were much younger, who had a risk of contracting sexually transmitted diseases, and henceforth, that's why you ask those questions. But I think that now, in a new era, older adults have that risk as well. And so very similar to questions that I asked to younger cohorts, I ask to older adults now too. And I think that, unfortunately, very similar to the qualitative data that I presented from the general practitioners, it's often not done for older adults. And I think making it routine, same thing that you would do for younger cohorts, you would do for older adults as well.
Especially, given that the older population is receiving more and more of these drugs that have direct impact on sexuality.
Completely right.
That an iatrogenic cause should be at least evaluated by the potential cause.
Right. Correct. Right. And I think that I think that you have to ask about a person's sexual health and how it plays upon their quality of life. Because the average patient might not bring it up to you, and I think that's one of the slides that I had, was that the women and men wished that their providers initiated the discussion, because very, very small percentage of patients will initiate that discussion if the provider, the healthcare provider, doesn't.
Yeah, the data on gynecological examinations was remarkable in terms of the absence of querying sexual behavior.
Right, and even a subspecialty, right.
There was a follow-up question regarding the multicultural concerns, or whether we need to better appreciate those, which was just whether or not if this research is being done or considered.
I think that I don't know the answer to that. Yeah, it would have to be done in different countries.
Okay, let's see. Just another question popped up.
I think we have a question here first. Do you mind, Michael?
Oh, please.
I was just wondering if the OBGYNs, being surgeons, if they would have a totally different way of approaching that, and if you'd get different answers if it were your primary care provider and doing your pelvic exam and asking questions. I don't know the answer to that, and so I can only talk about studies that. It would be interesting to do a parallel study.
Yeah, I think that on one of the slides it talked about specifically women who were going to subspecialists, the gynecologists, and then on the other side of that slide talked about primary care. So these individuals were going to their primary care doctor, and they spoke about the low prevalence of actually asking about sexual health and function.
One of our other remote participants has an interesting suggestion for clinical nuance.
Yeah.
As someone who is approaching the age group you've been discussing, I suggest asking, are you sexually active, rather than are you still sexually active?
That's excellent. Point well taken.
Anything else from our remote sites? We're coming towards the end of our presentation. John, is anybody else typing? Do you know?
I don't see anybody.
Okay. Well, in that case, I'm going to thank Dr. Ong for his presentation, thank our audience for their interactions and their participation, and leave you to Barb Cochran next week for number 4. Thank you all.